Our first presentation is by Dr. Sadia Farooq, and her topic is Innovations in Glaucoma Surgical Management.
Bismillahirrahmanirrahim. Respected seniors, dear colleagues, Assalamu alaikum. Right. So glaucoma has undergone significant evolution in last few decades from penetrating to non-penetrating and then mix. These innovations can be applied in a multitude of settings, and this is what we'll be discussing today. The objectives of my talk would be introduction to mix, evidence-based pressure-lowering effect of cataract surgery, gonioscopically assisted transluminal trabeculotomy or GAT, goniosynovitis, evidence in patient cases. When we say it's a surgical innovation, basically we look for better technique, faster technique, smaller incisions, quicker functional recovery, and better clinical outcome and survival. Why ab interno angle surgery is an innovation? There is a high risk of bypassing natural outflow, and there is a low risk of enhancing conventional outflow. This can be done by Schlemm's canal stenting procedure or by trabecular excisional procedures. Minimally invasive glaucoma surgery gives us targets of pressure of 17 to 18, which might be all right for patients with mild to moderate disease. Ab interno trabeculotomy reduces trabecular outflow resistance. This is done by creating a cleavage between trabecular meshwork and inner wall of canal of Schlemm. There is no blip, so no hypotony, no endophthalmitis. Minimal manipulation of conjunctiva and sclera is there, so it's minimally invasive and safe in scleral thinning. And there are minimal changes in astigmatism, so postoperative visual recovery is very fast. It's a safe technique. Direct gonioscopic visualization of angle structure helps us to identify the canal of Schlemm easily than ab externo procedure. And the evidence shows that wider excision of the trabecular meshwork gives us better control of intraocular pressure, especially in those patients that have higher baseline intraocular pressures. The indications of MIGS have now evolved and become better defined as for mild to moderate, primary or secondary open-angle glaucoma, pseudophakic, pseudoexfoliations, pigmentary glaucoma, and they are for early to moderate disease. When a patient of open-angle glaucoma has cataract, then Schlemm's canal procedure are an excellent adjunct to cataract surgery. IOP spikes are the most frequent complication and should be watched for if patient has perioperative hyphema. The only difference is different fundamental skills. So sitting temporarily, tilting the head of the patient, gonioscopic visualization, and ability to identify the angle structures. If a patient has got If a patient of glaucoma has got cataract and it's an early stage, then phacoemulsification is the best mix. All of us have seen pressure lowering effect of open angle glaucoma patients, even if they have open angle before the cataract surgery, to work as pressure lowering effect. So especially it's an ideal situation for glaucoma suspects and ocular hypertension. The mechanism is trabecular meshwork, extracellular matrix remodeling. It's effective and safe, and proven sustained lowering of intraocular pressure is there. In angle closure, the effect of lowering of intraocular pressure is proportionate to the resultant widening of the angle, and this can be predicted on AS-OCT by the lens wart that is interior. EAGLE trial confirms the efficacy when the pressure is higher in preoperative in those patients, so it's going to reduce after cataract surgery. Phaco alone, however, is not sufficient for those patients who have got synovial angle closure, and additional procedures are required, like goniosynovitis. So evidence supports the safety and efficacy of trabeculotomy 180-degree or less for open angle glaucoma patient with or without phacoemulsification who are on 1 or 3 anti-glaucoma medication. Those patients who are on maximal tolerable medical treatment or have uncontrolled intraocular pressure on medical treatment are best helped by GAT 360-degree with or without phacoemulsification. Angle closure glaucoma patient who have synovial angle closure, along with phacoemulsification, they must undergo goniosynovitis with or without ab interno trabeculotomy. Patients with advanced cupping, central visual field defects, or IOP spikes that can be troublesome for the patient, patients who have high risk of bleeding, and those who have early or late uveitis and angle neovascularization are not ideal candidates for angle surgery. So let's apply this evidence in some clinical examples. So one of my patients who had open-angle glaucoma, moderate cataract, and was on anti-glaucoma treatment underwent phacoemulsification plus 180-degree CAT and trabeculotomy. His IOP is well controlled on single medication with better visual function at 3 months follow-up. So after completion of phacoemulsification, the side port hydrodissection is done. Cohesive viscogel is placed in the anterior chamber and on the top of the cornea. Angle is visualized by using gonioscopic lens. And then trabeculotomy is done with the help of a 23-gauge needle. After opening the trabeculotomy, then 27-gauge bent needle is used to open up the inner wall of the canal of Schlemm by peeling off the trabecular meshwork. And this was done 180-degree. Another patient, young patient, pseudophakic, who has developed steroid-induced glaucoma, and this was uncontrolled on all tolerable medical treatment. Pressures were very high, and he was advised 360-degree CAT. His pressure went to 10 millimeter of mercury on first post-operative day and is still maintained without any anti-glaucoma medications at 1 month of follow-up. So the same initial steps, but instead of the needle, now we are using a fluoroproline stitch that is passed to a corneal tunnel created by 15-degree blade. With the help of a micrograsper, it is threaded into the canal of Schlemm, and then with repeated attempts until we could see the other end coming out. The other end is grasped with the help of a micrograsper. Gonio lens was put aside. And the end of the thread that was passing through the corneal tunnel that was grasped, and we could see 360-degree opening of the trabecular meshwork. AC was washed afterwards, and then anterior pressure was maintained up to 25 millimeter of mercury. This is the first post-op day of the picture of the patient. He's still doing well. One of my patients who had synechial angle closure and cataract came with very high pressures, 45 millimeter of mercury, and synechial angle closure was found to be there in 3 quadrants on clinical examination and on ASOCT. She underwent phacoemulsification and goniosynechiolisis. Her IOP is well controlled at 4 months follow-up without any anti-glaucoma medication and any further intervention. She is also advised early phacoemulsification in the other eye. So again, after the completion of phacoemulsification, cohesive gel is inserted into the angle. I couldn't find any angle structures there, so I proceeded with goniosynechiolisis with the help of a 23-gauge micrograsper. So goniosynechiolisis is basically pushing down the peripheral iris and separating it from the trabecular meshwork. And for it to be effective, it has to be done all around. So I had to go from the side ports, approximately up to 270-degree was completed. And once you do this, you can identify peroperatively angle structures. In another of my patient who had chronic angle closure, previous trabeculectomy was done, and the patient had a flat bleb. He was booked for bleb revision. At the same time, he was offered goniosynechiolisis and ab-interno trabeculotomy. He was a 34-year young male, so we wanted to do something more so that can make him medication-free. His pressures were pre-operatively 20 millimeter on beta blocker, and post-operatively under goniosynechiolisis, from the next day he had pressures 10 millimeter of mercury, and it is still maintained at 4 months of surgery. So in this, we can easily see the structures as the goniosynechiolisis is done and the iris is pulled down. So we can see trabecular meshwork now opened up, and now it is available for the flow of aqueous humor. So this GSL was done all around. So this is the GSL being done at the site where the previous iridectomy was there, at the previous trabeculectomy site. And then also going inferiorly, there were some iris strands which are separated carefully, and at the same time, I could see a trabecular meshwork all around. Just to make sure that the long-standing synechi wouldn't have caused permanent damage to the trabecular meshwork, I also added trabeculotomy to it, done with the help of the straight 23-gauge needle, and then with the bent, completed with 27-gauge needle. So we go at the site of the initial trabeculotomy until we feel the anterior wall of the canal of Schlemm, and then in the same, we move first in one direction and then 180 degree in the other direction. So goniosynechiolisis, a patient is good at 4 months with no medication. So I conclude by saying that we have now more options available for our glaucoma patients, more to offer to our patients. So this can be offered at any stage of their glaucoma paradigm. All we need to know is what is the right option for that patient at that particular time. Thank you very much for your attention.
Thank you, Professor Sadia. Now I will talk on glaucoma screening. Thank you, everyone. My topic is glaucoma screening in Pakistan. So the aim of this topic is that why do we need glaucoma screening, especially primary open-angle glaucoma, and how do we do it? So why we need primary open-angle glaucoma screening? It is because we want to know what is the actual burden of glaucoma in Pakistan. So far, there has been no population-based study which has answered this question. There are few hospital-based studies, but they all have variable results. Especially like in admitted patients, the results are different. In OPD patients, the results are very different. This is a 2 years audit of glaucoma in admitted patients in HMC Peshawar, and they reported that 22.4% of these patients were primary open-angle glaucoma. Another study that was also in admission patient, it was a national survey, about 6 or 7 institutes, they took part in it, and they reported that the open-angle glaucoma was 37.6% of their admission. But when it was compared with the patient presenting to the OPD, the percentage was very different. Like in Abbasi Shahid Hospital, the frequency of primary open-angle glaucoma, it was 74.9%. In another study which we published, it was 31.6%. So there is a huge variation in this result. The admitted patients, they have different results. The patient presenting to the OPD, they have different results. That is why we need a proper glaucoma screening program so that we have actual figures, what is the burden of glaucoma in our setup. And that is why, because the future of glaucoma, it is very different. In 2020, about 28.29 million of world population, 28.29 million in world, they all, for the Asian population, they are having primary open-angle glaucoma. And this figure has jumped to 42.32 million in 2040. So primary open-angle glaucoma in Asia is contributing more than 50% of glaucoma to the whole world. And it is not only primary open-angle glaucoma, it is primary angle closure glaucoma as well, and all glaucoma as well. So in all aspects, Asia is leading it. And we are part of Asia, Pakistan being the 5th populous country. Our numbers are missing in this. What is the burden of undetected glaucoma? More than 90% of underdeveloped countries and more than 50% in developed countries, the glaucoma is still undetected. And solution to this is effective glaucoma screening program with the goals to prevent visual impairment and to preserve the quality of life and visual function. Now, WHO has devised a screening criteria for every screening program. It's not limited to glaucoma, but every disease. And they say that for universal screening, the disease must be an important health problem. It should have a latent or early stage. It should have appropriate, acceptable, and reasonably accurate screening test. It should have accepted and effective treatment available. The cost of case finding must be economically balanced. Opportunistic screening must be a continuous process. Now, when we look this criteria in glaucoma perspective, we come across certain limitations and challenges. Number one, there is no systematic review that shows the links between glaucoma screening and its effect on visual field loss, intraocular pressure measurements, and visual impairment. Second, the cost effectiveness of glaucoma screening is still inconclusive. And which test or combination of tests should be used in these screening tests which improve the patient outcomes at sustainable cost. There are a few definitions, especially what is universal glaucoma screening and opportunistic glaucoma screening. Universal glaucoma screening means that inviting all the people from a community for the glaucoma screening. Opportunistic glaucoma screening is when a person goes to any healthcare professional, he should be checked for glaucoma. So according to the World Glaucoma Consensus, the opportunistic glaucoma screening program, it is a good option in glaucoma. It is preferred over universal screening. It is just an extension of usual clinical care. And it relies on detection in people who present for other problems. The main role players are general physicians, technicians, optometrists, and ophthalmologists. So the whole screening process revolves around these 4 people: the technicians, optometrist, ophthalmologist, and other health professionals. So how would we do it? The roles of non-ophthalmic professionals and ophthalmic professionals, they are different. Ophthalmologists, they are different. If a patient is coming to non-ophthalmic professional for any other reason, any problem, the non-ophthalmic professional, he should be good in comprehensive risk factor assessment, including the intraocular pressure and optic disc examination. This is very critical, that they should be taught about how to examine optic disc, at least. And in intraocular pressure, it is not a very difficult, because now we have non-contact tonometers, so it would not require that much expertise. But for ophthalmologists, the clinical examination should be comprehensive, and it should include all the tests which are required for glaucoma. Now the question comes to mind, who are the persons that should be screened for glaucoma? So the answer is any person who is older than 35 years and he presents to any healthcare professional, either ophthalmologist, non-ophthalmologist, he should be screened. And there should be focus on improving facilities, like educating the decision makers about glaucoma-related blindness, training of all ophthalmologists in glaucoma diagnosis and treatment, ophthalmic doctors, the optometrists, opticians, and technicians. And then advocating the provision of glaucoma resources within total framework of eye care. So these are those facilities which should be improved, and then we can implement effective glaucoma screening program. In the end, I will conclude that the opportunistic glaucoma screening test, it is the effective way for glaucoma screening. Thank you for your attention. Thank you.
Bismillahirrahmanirrahim. My today's talk is when to resort to surgery in the management of adult glaucoma. In fact, as early we have seen that glaucoma is a difficult disease from all aspects, to diagnose it early and to treat it effectively. So both of them are. Glaucoma is a term describing a group of ocular disorders with multifactorial etiology united by a clinically characteristic intraocular pressure-associated optic neuropathy. So we regard intraocular pressure as a risk factor, and it's very much important because this is the only modifiable risk factor at present. So most of our discussions and research is on this. Dr. Yousaf told you how much glaucoma is important, because it's a public health problem. 3.5% of global population aged 40 to 80%, 80 years of age, they are suffering from glaucoma. And it's the second leading cause of blindness and the first single cause of irreversible blindness. We know that cataract is the first leading cause of blindness, but we know that we can effectively treat it. We can effectively treat refractive errors, but once the eye lost from glaucoma, then at least we cannot reverse it. And we know that most of the blindness caused by glaucoma can be prevented by early diagnosis and prompt management. Many people fear blindness more than death. You just imagine if somebody asks you, would you like to be blind for your whole life? Or I think at least I will not go for life without vision. And preventing blindness from glaucoma would improve socioeconomic conditions in the world, because blindness is a very socioeconomically heavy disease, heavy burden on the resources. As earlier I said that intraocular pressure is the only the major proven treatment option for treatment of glaucoma. The goal of the treatment in glaucoma is to maintain the patient's visual function and related quality of life at a sustainable cost. We know that glaucoma is not a single time disease, it's a lifelong disease. And when you want to treat the patient, it's not only the vision that you want to save, but at the same time you want to improve his quality of life. And all them at a sustainable cost. All patients with glaucoma may benefit from adequate IOP lowering to slow or prevent disease progression. The mode and level of treatment are determined by several factors, including glaucoma subtype. We know it's not a single type of disease, multifactorial, and many, the mechanisms are much more different. Severity of disease at the time of diagnosis. The more the severe disease at the time of diagnosis, the more aggressive treatment then you need. And the same rate of progression, estimated life expectancy. If somebody have a longer life, you need to prevent his visual loss much aggressively. Visual prognosis and other ocular and systemic comorbidities. Every patient has a unique manifestation of disease and interaction between disease, treatment, and quality of life. There are no clearly defined and accepted rules to dictate when surgery is the appropriate therapeutic choice, but there are principles that guide to this decision. It is not possible to know a priori what level of intraocular pressure will be needed to substantially slow or halt glaucoma and preserve quality of life. We know, we talk about the target pressures, and we have different formulas to calculate that, but ultimately you have to look at the patient all the time, what happens to him with your management. It is not possible to know. Intraocular pressure lowering should provide risk reduction for the development or progression of glaucoma, and is not yet by itself the goal of therapy. So just to reduce intraocular pressure to some level is not in fact what we want. We want to prevent the progression of the disease at the same time with a quality of life. That's the graph, the home to treat graph. And in this we see that normally the there is apoptosis of ganglion cells with progressing age, but it takes you to the vision to your lifetime. And if this apoptosis increases and it causes severe functional impairment much before your life ends, then it needs aggressive treatment. And that's how we determine that when we want to treat and how aggressively we want to treat. We have evidence-based assessment of risk factors in glaucoma progression. And there are so many landmark studies which have determined the different risk factors for progression, which we have to watch during our treatment protocol. Normally, this is the normal glaucoma management flow chart. And we start treatment when we are certain that the patient has glaucoma and is progressing. There are different views when to start treatment with suspected glaucoma or ocular hypertension, but usually the treatment depends upon the progression of the disease, and once we are sure about that, we are going to start it. The medical management is the first line of treatment, and we usually start with the monotherapy, and then we look at whether it's working or not working. We switch between therapies, tolerated, not tolerated, and then we change. We may then, if it is progressing or not progressing. So all these, and usually surgery is regarded as the last option before we exhaust our other options. We have got many classes of drug available at present, and they have got different site of mechanisms. Generally, medication typically is the form of eye drop is the mainstay of treatment for many people with glaucoma. While effective at lowering intraocular pressure, many patients are unable to administer eye drops correctively. In a video study of drop installation in people with visual impairment from glaucoma, 1/3 of the subjects were unable to get a drop onto the eye. So in fact, they knew they are watched, and still they were unable to put it. So that's another thing which we have to consider. An even greater proportion of patients struggle with adherence. In a separate study, 45% of patients use their eye drops less than 75% of the time, despite knowingly they were being monitored. Reasons cited for non-adherence include forgetfulness, difficulty with drop administration, drug side effects, and regimes that requires multiple drops per day. In fact, we, in the treatment protocol, we look at whether the intraocular pressure is becoming a threat to vision. And this depends upon the degree of damage at present, what's that, the progression rate, the other treatments which are may be available or may not be available, or unsuccessful, and poor compliance. So all these leads to the decision for surgery. The indication for treatment is best defined as an identified need to reduce threat to vision. The decision for surgery should consider the risk-benefit ratio, optimum medical therapy and or laser therapy. Laser surgery fails to sufficiently lower intraocular pressure. In some patient does not have access to or cannot comply with the medical therapy. So if somebody does not have an access, progression of glaucoma, considering both the structure and functional integrity of the optic nerve, is clearly a threat to vision, and then you have to decide for surgery. Again, if the fellow eye of the patient has been lost from glaucoma, you may consider early surgery. Primary surgery may be indicated on the basis of socioeconomic or logistic constraints. Patients who are unable or unwilling to use their medical therapy as prescribed represent failures of treatment efficacy. Patients with advanced damage or damage threatening central vision may require lower IOP, and for that reason, we know that surgery is a better option for achieving a lower IOP. Extremely high IOP alone, particularly in an acute setting, can pose a sufficiently high risk of threat to vision to be an indication for surgery. So any patient presenting with more than 40 pressure, initially 50s, then probably you need to consider surgery much earlier. Whenever you need to add a fourth topical drug to control IOP, start considering surgery. Above 2 to 3 topical glaucoma medication, there is no evidence of increasing benefit by adding more. In addition, intolerance rises substantially with the use of more drugs. So in fact, thinking that all the available option drugs, put another one and put another one and put another one. In fact, it's not. The evidence shows that whenever the number of drugs goes above 2 or 3, then the surgery is a better option. Advanced damage of optic nerve at the time of presentation, age at the time of presentation. Although we know that age is a risk factor for progression of the disease, and so in older age people, you may need to have surgery earlier. And again, younger patients may need surgery early because of many years of useful vision to survive. Secondary glaucoma, especially with an angle closure component, will require early surgery. Pediatric and childhood glaucomas are typically indicated for the surgery. A blind, painful eye is substantial, and surgery may be indicated for pain relief. In this situation, surgery can improve quality of life. Warranting a cataract surgery in mild to moderate glaucoma, inserting a MIG device implant clearly benefits intraocular pressure. So this is how you go about glaucoma surgery, and these are different glaucoma surgery classification according to mechanism of action. Benefit of surgery. Early surgery addresses important issues such as promptness of treatment, advancement, and not dealing with the additional medication that are unlikely to further lower intraocular pressure. Avoiding unnecessary cost, because all the drugs are too expensive and you have to spend a lot. Limiting exposure to chronic inflammation associated with long-term polypharmacy to provide the best chance for surgical success. Because if you keep on giving topical drugs, it causes inflammatory ocular surface disease and the subsequent surgical failure. Tolerability of medical treatment and side effects along with compliance. Greater intraocular pressure lowering can be achieved with surgery than with medication in many patients. So whenever you need a lower intraocular pressure, probably surgery is the better option. Modern trabeculectomy techniques that include the use of laser, releasable, adjustable sutures has minimized the complication of excessive filtration. Excessive healing at the conjunctiva tenon fascia epicleal interface, the major cause of inadequate long-term IOP lowering after trabeculectomy, and judicial use of anti-fibrotic agents has largely addressed this problem. Modern MIGS has substantial evidence of intraocular pressure control at a much lower risk. The non-penetrating surgery has a lower risk, although with a moderate decrease in intraocular pressure. Evolving modern glaucoma drainage devices have increased scope for early surgery, especially in higher risk for failure of glaucoma. Micropulse transclear cyclophotocoagulation have improved chances of vision performance in complicated glaucoma. The risks of surgery, surgery is not without risk, and we understand that sometimes you may lose vision right on the table. Intraoperative risks such as suprachoroidal hemorrhage, failure to achieve target intraocular pressure, post-operative hypotony is another grave risk which will lead to maculopathy and permanent loss of vision, late bleb failure due to scarring, post-operative wipe-off, especially in end-stage glaucoma. Bleb-related endophthalmitis can result in rapid and profound loss of vision, and you may need many times repeat surgeries. So I will leave it here. Thank you very much for your attention. In fact, I took time, but I think there are so many trainees sitting, and probably it's very important when we are going to have surgery.
Now I'll ask Professor Zia Mazhry Sahab for his talk.
So my topic is end-stage glaucoma. So there is no need to be hopeless and make your patient hopeless. One should keep one's hope and one's patient's hopes intact. And Allah is very kind, generally. And most of the things from beginning to end have been covered by worthy Professor Nasir. So it will be quick for me. तो शेर वो दो ही सुनाता हूँ आजकल मैं. फितना ताज़ा की तरह काकुले पेचा. This is a curled hair which are dancing in front of a beautiful face. फितना ताज़ा की तरह काकुले पेचा. इस तरह रुए यार पे रक्साना हुआ कर. Please don't dance, oh beautiful girl, in front of that beautiful face. मुझसे चुरा ली है नज़र मिलने से पहले. You have taken away your eyes before meeting my eyes. इस कदर तो मोहतात मेरी जाना हुआ कर. प्रोफेसर सनाउल्लाह जान के लिए. मुझसे चुरा ली है नज़र मिलने से पहले. You have taken your eyes away before meeting my eyes. Don't be that careful, please. चलें, इतनी डोज काफ़ी है. So when do we label end stage glaucoma? देखिए इतने खूबसूरत शेयर और टॉपिक क्या है. जैसे डॉक्टर नासिर ने बताया, end stage glaucoma, that being a blind is even more painful for some patients than being dead. But this is how Allah has made this word a trial for His beings. This occurs when there is little to no healthy tissue left for normal functioning, for quality of life for the patient. And the blindness is quite eminent. But still we can do something. Even if your whole OCT is giving red signals, it's all red, and your visual field is all dark and black. Even an island of vision is so precious that we should try to preserve it. And I will share my experience regarding management of such cases. And as again, I will keep on referring to your great talk. 3 to 4 drugs, and still the pressure is not in control, and your OCT and visual fields are not stable, and very little is left. That is end stage glaucoma. There is a first case. He is an eye specialist, and he developed complaint of some limitation in his visual field, and went to one of his teachers, and the pressure was in late 30s, and the workup was advised, and the oral AZM and everything was started. It happened in 2001, and it's about 21 years long story, but I will cut it short for you. So they advised him, and then workup was done. So he had less than 10 degrees of visual field, and OCT was not available at that time. So immediately all the possible drugs, it was beta blockers and latanoprost with pilocarpine at that time. It was started with Esimox, but the pressure was not, they were not able to control the pressure. So one of my teachers decided to go for TRAB with injection mitomycin C. And it was initial phase of using antimetabolites, and a lot of hypotony used to occur. So he developed hypotony, and for first 2 weeks, the VN dropped from 6.6 to counting finger 660. But luckily, it settled with plasma injections, with patching, and all the measures, with AC formations 2-3 times in one eye. And he recovered good VN and became 6'9" again. But he did not go for other eye surgery because of that bitter experience. 2.5 years later, he developed cataract. The cataract was removed, and amazing thing happened. He developed hypotony again, and massive choroidal detachment developed. It was a successful, uneventful phaco with scleral incision, and with all the precautions. Don't let your AC get shallow, whatever is written in the textbooks. And unluckily, with all the efforts and the consultations available in Lahore and guidance and my teachers and his teachers, we were not able to recover any useful central vision in that eye. He got a central sectoma, and only an island of vision was left. So that led to natural decision not to go for surgery in other eye. And about 10 years later, gradually, the other eye became blind. And he kept on losing the field, and instead of advice, he never risked that I may lose it again. An amazing thing happened, which is quite unbelievable, and that's the lesson and essence of this talk. The eye with central sectoma and an island of vision assumed the function, and it quickly came up, and he was able to move around, and even he was able to count money. And with assistance, and he is very touchy about money, I know him very well personally. Even with this poor vision, he has not given that charge to his family yet. So he was able to make it with the help of the family, and even he is able to continue his job with the help of optometrists and kindness of his seniors. And this is happening for about last 5 to 7 years. And you know, the pressure in that eye is about 5 to 6. And it has, as I mentioned, so that eye which was kind of lost ultimately has become lifeline for that patient. So whatever we can do, we should do, and we should not hesitate to intervene in such cases. The second case is 58 years old male, and he also during his annual screening examination, his pressure was noted to be high. And immediately workup was performed in one eye. The visual field was within 10 degrees. And this story, he was diagnosed in 2005. And I, as an eye specialist, got into the picture in 2011-12. And he came to me with the reference because the pressure was in late 20s and early 30s, in spite of all the possible treatment available at that time. And everybody was hesitant, as you know, general culture is, that the modern day medical management has made us shy of interventions. First of all, I performed YAG PI in the same year in 2012. And then, even then the pressure was in 20s. So I performed trabeculectomy with injection mitomycin C. And he had 2 weeks of hypotony, but he did not suffer like our earlier patient. He recovered a good vision, and ultimately developed cataract in that eye, and we removed cataract, and a good successful phaco was performed, and he remained unaided 6'9", 6'6" in both of his eyes. And about 2.5 years later, he left for USA, and the pressure suddenly got out of control in other eye, and the surgeon in USA appreciated my work, and he said, I will do the same which Dr. Mazhry has done for you, but I will do it together. So he performed, instead of doing separate like me, he went for phacotrab, and the lucky man, by that time the experience in MMC and antimetabolites was better. So he recovered good vision. But to cut the story short, to date, I have personally about 6 and 7 interventions in both of his eyes. Twice I performed blebber vision with 5FU. And once I have revised it with injection MMC. Whenever the pressure goes near to 20 and the patient gets allergy to the medication as well. So this is just quick comparison. This is 2016, the earliest OCT I could find. This is 2019, and this is 2022. You see, it is all red, and there is a little deterioration in his right eye, but his left eye is almost the same. And same is true with the visual fields. 2014, and 2022. And almost similar picture in 2014 and 22 of his optic discs. And still he is able to drive with this visual field and with this OCT findings. The third case I will quickly go through. She came with acute red eyes and contact dermatitis with 4 drugs and oral acetazolamide, and pressure was again in 30s. And I explained everything. You have to develop a good rapport with the patient, that there is a risk of blindness as well. These are her pictures. And her visual field was almost dark in one eye and less than 10 degrees in one eye. So I performed phacotrab in one eye, followed by phacotrab in other eye. Again, separate procedures. And she was able to read Quran after break of years with one of his eyes. The other eye is 636 and one eye is 6'9", and mashallah she is having normal life, and this story spans over for last 4 years. So the lesson is that end stage glaucoma, and we had few interventions, bleb repairs and once or twice needling, and for that patient which I mentioned earlier, I last time saw him yesterday, and I am planning again. Now luckily Hila flow is available in Pakistan. So I am going to revise his bleb with injection Hila flow this time. That is quite safe as compared to MMC and 5FU. Because he is getting allergic to, we have again put him on anti-glaucoma treatment. Patient number 2. So whatever you do, you need a holistic approach. You need to develop a good rapport with the patient. You need to explain everything to the patient. And I refer back to Professor Nasir Saeed's talk. And anesthesia, you need to be careful. Don't let the pressure rise. Just give a little peribulbar and don't balloon it. Don't put a weight over the eye. You need to be touchy throughout the procedure. At no stage, let the AC get shallow, and at no stage of the surgery, let the IOP rise acutely. That's the lesson. And make a thick scleral flap and apply tight sutures. Shallow AC is our enemy. Don't let it happen. And be ready to cut the sutures in early post-op period or apply the slip sutures with slip knots. Don't be shy of the interventions. Explain it beforehand. And I tell you, if your patient has confidence in you and both of you have confidence in Allah the Almighty, you can save so many visions, and it will not be end stage as the name suggests. The patient will continue seeing and praying for you. Thank you very much.
Now I will call Dr. Hira Muazzam for her talk on medical management of glaucoma in pregnancy.
Bismillahirrahmanirrahim. I am going to discuss medical management of glaucoma in pregnancy. So, brief outline about my presentation. I am going to discuss the hemodynamics of pregnancy, pregnancy safety of anti-glaucoma drugs, trimester-wise management, and the potential side effects. So, in pregnancy, there is usually decrease in intraocular pressure, about 2 millimeters of mercury in each trimester. That is about 10% in total decrease, because of decreased level of endogenous corticosteroids and decreased episcleral venous pressures. So treatment is only indicated when the risk of damage, risk of disease progression outweighs the risk of the probable risk to the developing fetus. So I'm quoting 2 studies about intraocular pressures in on pregnancy. This study is published in 2012 in Clinical Ophthalmology, in the Journal of Clinical Ophthalmology. So it was, the sample size was small, and it was about 8 patients, and in total 13 eyes. So the mean number of anti-glaucoma medication decreases from 1.7 to 0.8. So this study was published in 2012 in the Journal of Clinical Ophthalmology, and though the sample size was small, but as a conclusion, the outcome was that and the number of glaucoma medication decreased from 1.7 plus minus 0.52 from before pregnancy to 0.83 plus minus 0.75, so a p-value of 0.04. Another article that was published in International Journal of Ophthalmology in 2016, and it was it quoted a study from 2013 that was conducted in Harvard University, and it is quite significant. It included 94 pregnant patients. 57% of the patients had IOPs and visual fields stable during pregnancy. 18% had increased IOPs but stable visual fields, and 18% of the remaining have progressive visual field loss with stable or elevated IOPs. So about FDA classification, category A drugs are those that are completely safe. Category B drugs are those that have no evidence of risk in humans, but animal studies have shown some risk, so they are possibly safe. Category C drugs are adverse events that have been reported in animal studies, and category D drugs are definitive risk but possible benefits, and category X are contraindicated in pregnancy. So trimester-wise management of glaucoma. In the first trimester, brimonidine alpha-adrenergic agonist is the category B drug. There is no category A drug in the topical anti-glaucoma medications. Timolol and timolol and other beta blockers, they are reported to cause cardiac arrhythmias and cardiac conduction defects during this period of organogenesis. Among the carbonic anhydrase inhibitors, they are reported to cause vertebral body defects and delayed fetal ossifications and delayed birth weights and metabolic acidosis. So they are also classified as category C drugs. Among the newer drugs, latanoprostene bunod and nitarsudil and others, rho kinase inhibitors, they have not been assigned any FDA category. In the second trimester, the first line drug is again brimonidine. Second line drug is beta blockers and carbonic anhydrase inhibitors, and we have to avoid prostaglandin analogs in this trimester because they can cause intrauterine contraction and lead to spontaneous abortions. Third trimester is divided into early third trimester and the late third trimester. So in the early third trimester, first line drug is brimonidine, and we can give beta blockers in the early first trimester too, but they are the second line drugs. They are given cautiously because they can cause fetal bradycardia, so we have to monitor the fetal heart rate. Second line drugs are carbonic anhydrase inhibitors, and we have to monitor the metabolic acidosis and avoid prostaglandin analogs in early third trimester. In the late third trimester, beta blockers are the first line drugs. They are among the category C drugs. So carbonic anhydrase inhibitors are also given, and they are also the first line drugs in the late third trimester. Second line drugs are prostaglandin analogs in this late third trimester, and we have to avoid brimonidine or alpha-adrenergic agonist because they can cause CNS depression in the newborn. So at labor or during lactation, the first line drug is prostaglandin analogs. To summarize, from conception till 36 weeks, the drug of choice is brimonidine as first line drug, and from 36 weeks onwards till 40th week, the drug of choice is beta blockers and prostaglandin analogs. Thank you.
Thank you, Dr. Hira. So with this, we come to the end of this session. I will ask Professor Nasir Saeed, who is the chair of this session, to kindly give the shields. And there is one announcement. Please be seated here because the plenary session will start and the cards for the dinner, they will be distributed in this session. So, 4 sheet. Professor Sadia Farooq. Dr. Hira. And Mir.
Dr. Yousaf Jamal.